surrounded by a lot of gadgets nowadays. But for refraction as such, you need very little gadgets. You just need a trial set. You need a good retinoscope in the form of a good streak retinoscope and a trial set. That's all that you need for a good refraction. But you should understand that in addition to this, what is not mentioned in this slide is, along with that, you should have a basic knowledge of what retinoscopy and refraction is like. So that's probably the most essential thing in refraction than these things. So, before doing into how you enrich your refraction, I think I will spend 2 minutes on the basics of retinoscopy and refraction. So, either with a streak retinoscope or with a reflecting retinoscope, what you do is you reflect light onto the. So, patient is seated in front of you. For ease of or convenience of calculation, we will say that the patient is seated 1 meter in front of you. With this retinoscope, you reflect light onto the patient's eye. So this illuminates a patch of the retina. So this light gets reflected back. So the source of light, the illuminated patch of the retina, acts as an object, and that forms an image at the far point of the patient's eye. So I seated 1 meter in front of the patient. You have thrown light into the patient's eye. There is as an object, there is that light patch on the retina, and it's reflected back, and that gets focused at the far point of the patient's eye. So what you want to find out is, why is the far point of the patient's eye? So the far point of the patient's eye in this situation will depend upon whether the patient may be either emmetropic or myopic or hyperopic. So the far point will depend upon. So this is what I said. The emergent beam will come to a focus at the far point of the patient's eye. So you can't go in search of the far point. The patient. So what you do is, by retinoscopy, you bring the patient's far point to your eye. So you make the patient's far point as, if you are working at 1 meter, at the what you call as a neutralization, you have made the patient's far point as your eye or your working distance. So which means you have made the patient at neutralization myopic to the extent of -1 diopter, because, so we will again see. So suppose, so I told the patient can be myopic, hypermetropic, or emmetropic. So do we have the other point? So you see the second line. And if the patient is myopic by 1 diopter, his far point is at 1 meter. So when you are seated 1 meter in front of the patient, and the patient in front of you, if he is myopic by 1 diopter, even when you start the retinoscopy, you find that it is neutralized, because the patient's far point is your working distance. So what will you do in the cross? You write as 0, 0, right? Because utterly it is neutralized. Because you have made the patient is already myopic to the extent of -1 diopter. So from the 0, 0, you put -1, the patient's refractive error is -1. That is what it means, right? So we will see the other things also. If it's an emmetropic eye, the rays are reflected back, and the far point of the emmetropic patient is infinity. So the rays will go and focus at the far point is at infinity. So when the patient's far point is at infinity, you can use a lens which depends upon your working distance to bring it to focus of your eye. So if the patient is emmetropic and the rays of light are divergent and it goes to infinity, if your working distance is 1 meter, if you put in +1, no, it will be, the far point of the patient will become your eye. And if it's an hypermetropic eye, the far point is a virtual point behind the patient's eye, and the rays from there are divergent. So depending upon the hypermetropic status of the patient, the rays will be divergent, and you will have to have this virtual divergent rays, the far point is virtual, but the rays are divergent. You have to bring it to focus to your eye. So, we saw that if the patient is myopic to the extent of -1 diopter, if you are working at 1 meter, even when you start, it is neutralized. So, we will see. Suppose we will go to this line again. If the patient is myopic to the extent of 2 diopters, so what happens? The patient's far point is ½ meter. So, the rays from the patient's eye, so the patient's far point is between you and the examiner and the patient. So, the rays from the patient's eye converge between you and then it diverges. So, what you see is the rays once converged and then diverged. Suppose the patient is myopic to the extent of 0.5 diopters. Myopic but 0.5 diopters. What happens? The far point is at 2 meter, so it is focused behind your eye. So, any situation where the patient's myopia is more than 1 diopter, if your working distance is 1 meter, it will focus between you and the patient and then start diverging. That's why you get an against movement in myopia. Whereas in all the other situations, the patient is myopic less than 1 diopter, or the patient is hyperopic or emmetropic where the rays is divergent or parallel, which has been focused between you and the patient. There you get a with movement which is neutralized with a plus lens. So, and with that value which you get in the cross, you have made the patient myopic to the extent of -1 diopter, and you subtract from that, and you get the patient's refractive status. Assuming that we are not considering if the patient does, we are putting in cycloplegic or not. This is just for the distance correction. I mean, working distance correction. If there is a strong cycloplegic, you make the cycloplegic correction as well. Okay. So that's the basics of that. So this we have already told. So then, ideally when you do a refraction, you do an objective, and for doing an objective refraction, for doing retinoscopy, it is not always a must that you should dilate the pupil. If the media is clear and the pupillary diameter is sufficient enough, especially in almost all the young patients with a clear lens, you can do an retinoscopy. Ideally, you start with an objective before going to the subjective. So, to enrich yourselves, if you want to, so what are the things you have to have? You should have a good streak retinoscope, and also you should know how to use a streak retinoscope. What is this virgin sleeve is like, or how do you make use of that? So, a good understanding of the streak retinoscope and the autorefractometer. So, because days are changing, you should have gadgets with you to have patients with you. And autorefractometer is an instrument which can be a good companion for your refraction practice. But you should know the problems that it will create, especially when you do autorefractometer in children with good accommodation. What happens is, in this refractometers, you have an object between, the patient is looking at the object inside the refractometer, and the patient tends to accommodate, so it brings in more minus power. So that's the problem. So to make good for that, you have got what is called as an open field autorefractometer, where the object is apparently at a far distance and the problem of accommodation will not come in. So this is another set of gadgets which will help you. This is called photo screeners, especially in screening of small children, pre-verbal children. If you want to screen, you can make use of these gadgets. We'll see how we make use of this. So it's most of you might have heard what's a Brecken's test, where you can do with a simple ophthalmoscope, you see the reflex of the pupil. So this is basically based on that Brecken's test. So just 1 minute. So it's essentially a photograph of the patient's binocularly it's taken, and you look at the reflex, and in an emmetrope, the retinal reflex will be uniform across the pupil, whereas in myope, what will happen is, if you look at the reflex, there will be a crescent at the bottom of the pupil. In a hyperopic reflex, it will be at the top of the pupil. So it will help in screening, not the exact dioptric powers it will give you, but in a large scale screening of pre-verbal children, it will be useful. So even this duochrome test will help you probably. I think you just read it up because the time is over. Normally it should be for the spherical final correction, 0.25 correction, you can make use of this duochrome test. How you evaluate it, if we get time, I'll tell you later. And actually, and also this is a simple but useful instrument for the final refining of the cylindrical correction, the Jackson's crow cylinder, and even these small gadgets which are not costly at all, even a synopic slit can enrich your refraction for finding out the principal axis of astigmatism in a case of, because it's a very simple instrument, but if you know how to use it, even this can enrich your practice. Thank you.
Thank you, Professor.